My name is.
Good evening, sir.
My name is Justice Baole, and just for the sake of our friends who are joining from various places, I'm the Dean of the Business School at the University of Ghana. This evening, as part of our COVID Business and Society Seminar series, we have another session which promises to be very exciting. The COVID Business and Society Seminar series was instituted some 2 months ago with the objective of creating a platform for scholarly and practitioner knowledge sharing. The essence of this is to ensure that we are able to disrupt thoughts, and in the process of that, we will help to shape thought in an attempt to influence policy and practice. We all know that in this era of fake news, if there is no credible news, fake news reigns. And so our objective has been to help to lead the conversation and to push the agenda to ensure that we dominate the airwaves with credible news about the impact of COVID-19, about how it is affecting business and how it's affecting society. We have had some very renowned scholars and practitioners speak on this. This evening, we are privileged to have two very important personalities whose expertise cut across a broad spectrum of political economy, health economics, medicine, and health policy. We have two presenters. The first presenter is Dr. Abekah-Nkrumah. Dr. Abekah-Nkrumah is a senior lecturer here at the University of Ghana Business School, and his area of research is in the area of health economics. He addresses his health economic analysis using political economy analysis and lenses. This evening, he will be talking to us about achieving universal health coverage, potential reforms post-COVID. Gordon will be the first to speak. I will give a little gist about our second speaker so that he is not lost, but I would give a detailed introduction of him when he's about to speak. As we have it always, we have up to 30 minutes or so of presentation, and there is a Q&A session afterwards. Our second speaker is Dr. Anthony Nsiah-Asare. I am sure that he's not a new name and probably doesn't require an introduction. But for the purposes of this event, he is currently the advisor to the president on health. He is the advisor to the president on health, but we know him within the practitioner and the academic field because not long ago, he had played very significant roles. He has played very significant roles within the health sector, both at the practice level and at policy levels. This evening, he will be talking to us as well after Gordon's presentation. But I'll give a more detailed introduction of him and his extensive background when he has to give his presentation. So, ladies and gentlemen, as we always have, we already have 57 people here, and we hope that a lot more people will join. Let me welcome you, Dr. Abekah-Nkrumah, to start your presentation. And as he's at it, if you have a question, please, you can go ahead to already put your question in the chat, the group chat forum, so that it can be read to him while he finishes. Otherwise, when he is done, you can put your question there. We crave your indulgence to keep your microphones shut so that we will not interrupt the conversation. Dr. Abekah-Nkrumah, the floor is yours now. Please go ahead, and we are all ears to listen to you.
Thank you very much, Dean Bowley, and good evening to all the listeners and participants. Hope I'm loud and clear, Dean Bowley.
Yes, you are.
Okay, so thank you very much once again. This evening, as you said, I hope to lead some discussion on achieving universal health coverage in Ghana, specifically implications for health systems reforms. So this will be my outline. Look at the health system overview, some background information, goals and how it aligns with the SDGs. We'll look at the ongoing demographic, economic, and epidemiological transition, how that dovetails into the capacity of our health systems to help us to achieve our goal and potential recommendations. So because I know that there are participants who have joined us from outside of Ghana, I want to just spend a few minutes to try and give an overview of our health sector, its structure, and how it works. So in Ghana, the Ministry of Health is at the apex of the health sector, and then it's entirely responsible for policy formulation, and it has entities that are responsible for implementation. And under that, we have service delivery, regulation, training, and then financing and purchasing. So if you look at service delivery, you have the Ghana Health Service, SHAG, Ghana Association of Quasi-Health Institutions, the teaching hospitals, then you have private sector, then you have regulation. Regulation is done by two entities, those that are for the professions and those that are for service deliveries. And then we have training done by the public sector and then the private sector. And we have financing and purchasing done by the public sector, which is purely the National Health Insurance Authority and the government of Ghana. And you have private sector, which works through voluntary private health insurance, mutual health insurance, and individuals making payments at the facility level, which we normally call out-of-pocket payments. So having dealt with the background, I must say that over the last 2 decades, there have been several reforms within the health sector. These are structural reforms. For instance, it used to be one ministry before. It was now divided into policy and implementation, like I've shown you. We can talk about the sector-wide approaches reforms. We can talk about the health insurance, procurement and supply chain, several financial management reforms. This is to just mention a few. There have been several reforms in the sector. And thankfully, these reforms have yielded positive outcomes, okay, reflected in the sort of outcomes that we've generated over the last 20 years. So for instance, maternal mortality has reduced from 760 in 1990 to about 308 in 2017. Percentage of women receiving 4+ antenatal visit has increased from 78% in 2008 to about 87 in 2014. Women delivering in health facility has also increased from like 42% in 1988 to about 73 in 2014, according to the DHS. If you look at infant mortality, there being a reduction from 28 to about 44, reduced by 28 and 44% respectively. That is for infant and under 5 mortality. If you look at under 5 stunting, wasting, and underweight, tremendous reduction based on the 2014 Demographic and Health Service. So basically, one of the things that we can say is that these reforms have actually been positive in terms of influencing health outcomes in the sector. And that's a good thing. And based on these sort of positive outcomes, the sector is in the frame of continuous improvement to be able to upscale the progress that we have made and continue in that process. And through that, a key objective, which is captured in the health sector program of work, which is the strategic document, or what I'll call the overarching document that actually leads the health sector. A key goal captured in there is that of improving access to quality, efficient, and seamless health services that are gender and youth-friendly and responsive to the needs of all people of all ages in all parts of the country. And basically what I'm going to do is to look at this overarching goal, which is also itself linked to achieving the health sector related SDG, which is SDG 3, and try and do some sort of situational analysis in the context of the targets that are associated with SDG 3, so that we can begin to see where we are hovering. But of course, because the SDG 3 targets are a lot, I'm not going to look at all of them. I'll just pick some of them, and then we can just do a status analysis to begin to find out where we are at the moment. So for instance, if you look at the target, which says that by 2030, we will reduce global maternal mortality ratio to less than 70 per 100,000. How is Ghana faring right now? So for instance, if you look at the 2017 maternal mortality report, Ghana is currently hovering around 310 per 100,000 live births, which is way above the 70, which is the benchmark for the SDG by 2030. And in some instances, what I'm trying to say is that in some regions, the rate is somewhere around 402, and the lowest is about 217. Now, if you look at the inputs into maternal health, things like place of birth. So yes, we've made substantial progress looking at the data between 2007 and 2017. So for instance, health facility deliveries moved from 54% to 79, which is a great improvement. Home deliveries decreased from 45 to about 20%. Now, if you look at trends in antenatal coverage, for instance, ANCs by skilled providers, 4+ antenatal visit, and ANC in the first trimester, all of them have witnessed some sort of appreciable progress. But even though the inputs are making progress, and we're making progress in maternal mortality, the data shows that we still have a long way to go. Now, if you look at the aim that says that by 2030, we'll end preventable deaths of newborns and under 5 and reduce neonatal mortality to 12 per 1,000 and reduce under 5 to 25 per 1,000. Now, if you look at the data, even though we are on a downward trend, which is a good thing, the numbers are still quite high. So, for instance, if you look at neonatal mortality, we are supposed to do by 12, but currently we are somewhere around 25. If you look at, I think, under 5 mortality is supposed to be 25, but the current one is around 52. So it means that we still have a long way to go in terms of the problems that we have to solve. Now, what about the aim that talks about ending AIDS, tuberculosis, malaria, neglected tropical disease, and combating hepatitis, waterborne diseases, and other communicable disease? Again, in this area, we've made substantial progress in terms of reduction, okay? But the point is that malaria still continues to be the top killer, the top causes of mortality in Ghana, showing that we still have a long way to go. We've been able to reduce the prevalence of HIV/AIDS to about 1.6% among the general population, which is quite good. What about non-communicable diseases? That is a difficult area because right now, non-communicable diseases account for about 43% of all deaths in Ghana, and NCDs have actually featured constantly in the top 10 causes of morbidity and mortality, as well as causes of inpatient admissions in Ghana. Then the other one is talking about strengthening the prevention and treatment of substance abuse. Substance abuse amongst adolescents is about 12.7% to about 25%. Alcohol consumption is also on the increase, as well as use of narcotic substances. Now, the part which talks about deaths and illness related to pollution, we can see from this graph that pollution is actually on the increase. Okay, so we still have a long way to go, and I will just cut it here in terms of the goals. What about increasing health financing, recruitment? If you look at this graph talks about the doctor-patient ratio in Ghana, and you can see that the doctor-patient ratio is actually high. So for instance, in places like Upper West, we have doctor-patient ratio of more than 25,000 patients to a single doctor, okay? And then if you look at the nurse, we have about 600 in places like Eastern region, in places like Western region, okay? And then in Ashanti. But outside of the sheer numbers, the distribution is also an issue. So for instance, if you look at absolute numbers, most of these health staff are concentrated in Accra and Ashanti region. But if you look at it in terms of taking into consideration the population density, then you can see that even with the population density, Accra tend to have something below 5,000, both in 2016 and 2017, compared to Upper West, which is over 25,000. And so there are huge inequities in terms of distribution of healthcare personnel, in addition to the fact that the numbers are a problem. Now, even after we've talked about the numbers and these other issues, there is also currently a huge issue with equity, okay, in terms of availability of services. So for instance, if you look at public services, we know that public services, because of the health insurance, is supposed to be free. But the point is that delays in utilization of services make the opportunity cost of using services extremely high. And I have argued that I even think that services delivered in public facilities are more expensive than services delivered in private facilities. Even though the actual amount of money you pay at the public sector is low, the opportunity cost of your time in terms of waiting time is so much such that public services tend to be more expensive. And if you look at the data, if you look at these concentration indices, it shows that almost all public sector facilities, both from clinic, health centers, district hospitals, regional and teaching hospitals, are all concentrated among the rich. Now, if you take the private sector services are also concentrated among the rich. The only service that is concentrated among the poor is self-treatment and pharmacy and chemical sellers, which is, of course, understandable because poor people are not able to afford going to stay in queues in hospitals for a long time. And so what they would do is just go to a chemical seller and just buy some medicine and just go ahead with their daily business. And the only time they will go to hospital is when it's the last resort. They have nothing to do. Now, aside use of services, if you talk of other outcomes like nutrition, it's highly concentrated amongst the rich. So for instance, I used both the 2003 to 20 and then the 2014 demographic and health survey data to plot this concentration curve. And the blue line is the line of equality. The red one is actually the negative of height for age Z score, which is long-term malnutrition. And then that is for 2003. And then the same negative of height for age Z score, which is long-term malnutrition for 2014. And you can actually see from the graph that the inequality, okay, with respect to long-term malnutrition has actually even increased from 2013, which is the red line, to the lemon line, which is 2014. So inequality is actually increasing. And so it means that the rich tend to have access to better services, better nutrition than the poor. And these are all issues that we need to deal with. But you see, having talked about these issues, I would want us to pause there, and then I'll begin to look at other important issues that can aggravate the sort of situational analysis that I've given you. And that is the demographic, economic, and epidemiological change. And basically what I'm going to do at this session is to try and look at our demography, match it with our economic situation, and see the implications of it on our epidemiological trajectory. Now, in terms of demography, yes, one of the things that we are looking at is fertility. Fertility rates have reduced, but the fact of the matter is that they haven't reduced as sharp as we want. So for instance, the 2017 maternal health survey shows that on the average, a woman gives birth to about 3.9, which is quite high, so it's about 4. And in some regions, if you look to the right, in the northern region, it goes to as high as 5.8. Okay, so what it means is that mortality, fertility rates are high. And because fertility rates are high and we still have issues with family planning, what it means is that we are going to have more people, and it has implications for the amount of people that are exposed to risk. Again, our population is also young. Majority of our population is under 5. And now that we're getting into issues of NCDs, which I'll come to very soon, what it means is that people are going to have exposure to NCD risk, and they'll have these diseases for a long time, okay? And managing these diseases are also quite expensive. Now, aside of the demography is also our economic trends. Over the last 20 years, we have improved in terms of economic growth, which is a good thing. For instance, if you look at per capita GDP has increased consistently. In 2013, it was a major jump, but you can still see up to 2018 that per capita GDP is being on the increase, and this is fueled by the growth, which has mainly been powered by growth in the oil and mining sector. Of course, it is good to grow, but these growth are fueled in areas where employment is not massive enough. Now, the growth has also been aligned with reduction in poverty. So, for instance, if you look at 1991, the poverty rate was around 51.7. In 2013, okay, the poverty rate had been cut by more than 50%. So the joint effect of these two, together with rapid urbanization, is the fact that we now have a new category of people who have the pocket, the purchasing power, okay, and coupled with urbanization, have effect on lifestyles. And these are lifestyles that are recipe for contracting NCDs. So these two, together with our demographic profile, is now creating a change in our epidemiology. Over the about, let's say, 15 to 20 years ago, most of the things that we could talk about in Ghana is mainly communicable diseases. But now, if you look at our top 10 causes of morbidity and mortality, you can see that, yes, we still have malaria in there, but now we're beginning to have things like hypertension, which is number 3. So here, this is the top 10 causes of admission of all ages. Hypertension is number 3, okay? And then you have diabetes to be number 10. But if you come to the top 10 causes of mortality for all ages, now you have hypertensive heart diseases to be number 1. You have things like cerebrovascular diseases to be number 4. And then you have diabetes to be number 9. And then you have other heart diseases to be number 7. This is from the Ghana Health Service. And the other one here is from the Center for Disease Control. Stroke is number 5, okay? Diabetes is number 10. So basically, the changes in our demography, the economics together is creating a new dynamic in terms of diseases for Ghana. So now, unlike before, where we had just a single burden, now we have what we call a double burden of disease. And so this sort of situation demands that we have a much stronger health system to be able to deal with these sort of issues that we've talked about. Now, I am going to rely on the standard WHO health systems blog for us to now begin to talk about the health systems that we need to be able to deal with these challenges that I have enumerated. I mean, basically, WHO talks about 6 blocks, which is leadership and governance. They talk about financing, human resources, information systems, service delivery, and access to essential medicines. I'm one of those who have argued that the WHO building block is not complete because it basically argues from only the supply side. Leadership, as is articulated in this context, is from the supply side. Financing is also about supply. Human resources is about supply. Information systems is about supply. Service delivery is about supply. Access to essential medicines is about supply. But there's got to be both a demand and supply argument. And so I have introduced what I will call a 7th block, which I call the people, okay, and the communities within which these services are delivered. And the reason why I think that this is important is what I've already explained. But quite recently, I've even been more convinced about the need to have this 7th block. Now let's look at COVID. I mean, COVID, I believe, even though we all think that is a big deal, but I don't think that COVID is such a big deal that should overwhelm a country that has a strong community-based participation in health delivery. Because what is it? COVID is an infectious disease that has no cure. And so the major way to dealing or managing with COVID will be based on a strong primary healthcare system with a robust communication strategy aimed at changing or modifying behavior. And that is something that you would do if the communities are part. If you look at the communication that accompanied COVID in Ghana, almost everything was done from the top, from the presidency, when we started having all these briefings. Now we are having people not wanting to do social distancing, not wanting to put their mask on because everything is coming from Accra. But if we have a more robust community-based engagement as part of our overall health system, my guess is that this should have been dealt with at the district level, who will work together with traditional leaders who would then be able to sensitize their people, who they are close to be able to deal with these things. So that's the reason why I've introduced this. Now, I'll pick these blocks one after the other. And what I'm going to do is to look at these blocks in terms of the challenges that we have, which would undermine our ability to have resilient health system that will be able to deal with the challenges that I've enumerated. And then at the same time, I will then suggest what we need to do. So one of the issues that I believe can compromise our ability to deal with the challenges that we have is what I call complex and fragmented agencies under the health sector that need stronger coordination from the center. Okay, that is one. You have too many agencies. The center does not seem to be as strong as it needs to be able to coordinate all these entities. And this is compounded also by the over-politicization of the bureaucracy for the health sector. The other one is also the blurred boundary between bureaucracy and politics, which I have talked about. And then what we also need is some sort of, or what is a bit absent is a national level strategy, which is strong enough to be able to harmonize resources and efforts within the sector. And the last one is stronger leadership within the sector to be able to galvanize the sector in terms of developing strong strategy and deploying that strategy to be able to achieve the aim of the sector. Now, in terms of essential medical products and technology, so one of the issues here is disparity in the distribution of medicines and medical products across the country. And that's something that we need to deal with. We thought that the central medical stores, which cascade into the regional and then the district medical stores, will be able to deal with this issue, but it doesn't seem to me that that has been done. And so people rely mostly on the private sector with varied prices, and so access to medicines tends to differ across the length and breadth of the country. And this leads to high cost of medicines, which tends to be quite huge and a major driver in terms of the expenditure for the national health insurance. And it's something that we need to address. And again, there is also the need for right environment to be able to promote innovation and entrepreneurship, especially for medical products and technology innovation. We can then talk about health information systems. Major issues there are about synchronization and alignment of information across institutions. I mean, sometimes it's difficult to have data for a single sector. You go to Ghana Health Service, what you get is different from what you may get from the Ministry of Health or what you may get from Kolebu or the Food and Drugs Authority. So that is an issue that we need to deal with. Again, the issue of adoption of technology. One of the things that I've talked about is that if we can upscale technology in the sector, we probably should be able to reduce the inequities in terms of human resources. Now we are talking about having to drive the issue of distribution of human resources and having to train more people because we don't have enough. But I believe that the adoption of technology can help us to be able to scale up as quickly as possible. And that is something that we seem to be quite behind. Again, when we talk about information, again, we can say that looking at the way we manage information on COVID to citizens, it tells us, which is what I just talked about earlier on, that our risk communication system doesn't seem to be working as much as it should be. Else, we should have been able to deliver a lot more information on COVID, and now we shouldn't be having issues with people abiding by the social distancing protocols. Now, in terms of service delivery, a major issue is the lack of clarity on our approach to service delivery. Are we concentrating on prevention and promotion, or our focus is on curative care? That is an issue that we need to address and be able to link that to the package of services that we believe responds to the needs of our epidemiological profile, and link that to the package of services that our financing mechanism, which is the NHIS, would be willing to fund. A key issue, again, is challenges with the quality of services that are delivered across board from primary to tertiary. And that is also combined with issues of inefficiency. And so we need to begin to address the issue of how we want to look at our service delivery structure. Do we want to continue to say that the Ghana Health Service should continue to be in the hands of the government, or we want to look at some sort of a model where all the facilities can now become autonomous, running under a different agency, probably the district assemblies, or they are running as autonomous entities. They are providing services. They are responsible for their own staff. They pay their own staff. and then the national health insurance will be reformed to pay realistic rates to these entities. We believe that that can be a way of dealing with quality as well as efficiency issues. There are also challenges in terms of harnessing the value of existing infrastructure to improve service delivery. Over the last couple of years, probably 15 years or 10 years, we've made huge investments in infrastructure, but it does not seem, based on evidence, available, that we are really harnessing the value of these investments to be able to deliver service that have value to our patients and that respond to the needs of the people. And finally is the issue of integrating the private sector into the entire service delivery so that we can have one whole service delivery and we'll be able to find out everything that is happening within the sector. Human resources. I think the key issue here is numbers and then the skill sets. Again, the other issue is how we begin to build the new caliber or the new cadre of health staff who will be able to respond to the threat posed by NCDs. And the third one is the stark inequalities in terms of distribution. I mean, I would say that COVID has actually exposed the inadequacy in our human resources for health. Right now, people are being redistributed. And if you go to the hospital and you gather information, a lot of procedures that they consider to be non-emergency are being put on the hold because people are being redeployed. We don't have enough anesthetists, and if you need to put somebody on a ventilator in the critical care unit, you need anesthetists. And so because of that, surgeries in a couple of hospitals are actually being postponed. My sister is supposed to go for a surgery, but they are postponing it because they said that they are overstretched. So we need to begin to look at issues of developing human resources. And here the issue is in terms of numbers, the issue is in terms of distribution, and then the issue is in terms of the unique set of skills that we need to be able to respond to NCDs. And the other one is financing. For financing, we need to be able to address issues of out-of-pocket, and then we need to address issues of inefficiencies within the NHIS. But the key issues that ought to happen here is for us to begin to have a discussion on how we finance NHIS and the way we recalibrate NHIS to be able to deliver on its mandate. So the argument is, should we say that issues about paying premiums and all those things should be scrapped because it tends to be that right now, if you look at NHIS, it tends to be more of the rich and not the poor because the poor do not have the capacity to be able to pay premiums. And sometimes, even though they are not supposed to pay premiums, even renewal is an issue. We probably need to have a discussion. Should government say that, look, nobody pays any premium. Everybody, as long as you are a Ghanaian, you have access to NHIS, but we define a threshold package of services that everybody has access to. And once they go to hospital, NHIS will pay for that. Do we also need to have conversations around how to insulate NHIS from the political class, and also how to insulate the NHIS funding from the central government, so that the issues of delays in terms of reimbursement from the Ministry of Finance to the NHIS, then to the health facilities, will all be dealt with. We also need to begin to think about how to reform NHIS around claims processing, claims management, and then abuse. Because if you look at the current medical loss ratio within the NHIS, it's at about 25-65, which is so high. The 25 is above the threshold of 10%. So these are things that we need to look at. And of course, community participation. We need to think about community participation. We really need to re-engineer our systems to be able to give the communities a role to play in the delivery of service, because after all, they are the people that we are taking care of. And so we need to begin to re-engineer the systems that we're putting in place to take account of community participation and be able to deliver behavior change messages. Because for NCDs, for pandemics, and for disaster, the major tool is about communication and behavior change. So I think that these are the things that we need to do. The same things, I have put them in terms of recommendations. And these recommendations, we're looking at the immediate issues for implementation, issues for medium-term implementation, and issues for long-term implementation. They are basically some of the things that I've talked about, so I don't want to go over these issues again so that we can have enough time for questions and discussion. Thank you very much.
Thank you very much, Dr. Gordon Abekah-Nkrumah, is senior lecturer here in the University of Ghana Business School. He's been talking to us about achieving universal health coverage, implications for health systems strengthening in Ghana. Ladies and gentlemen, I would want to open the floor now for questions. If you have any questions.
So can I put off my slide?
Yes, you can. You can. I mean, you can. Yes, thank you. So let me. If you have a question you want to show by hand on the system, or else you can unmute yourself and go ahead to ask your question. Koshi has put a write-up here. Let me try and read it. You emphasize the need to decentralize health system delivery from the center to the local authorities. Is that realistic? Because these districts have failed in delivering basic public goods. Classic example is the sanitation problems in our communities. Would it be too risky to entrust essential public goods such as health delivery to their hands, the hands of the local authorities? And he is, Kosi Fiagbe is at the economics department. So, Gordon, do you think that it's too risky because we're not sure about the capacity of our local government to properly deal with? Joseph Antwi, Boshiakun.
Do you want me to answer that?
Yes, you can answer this one first.
Okay, so thank you very much. I think what I would tell the participants is that, look, even if you look at it from the national level, we can say that we don't have capacity when you compare it to other countries. So capacity is relative and capacity can be built. It's just an issue of, do we think that that is the right thing to do? If we believe that that is the right thing to do, then we can build the relevant capacity at that level to be able to deliver the objectives. I think that it is the right thing to do. Because I'll give you a typical example. So let's talk about COVID. How do you think COVID would have panned out if, for instance, all the communication that was coming from the Ministry of Information and the presidential briefings happened at the district, and the district worked together with chiefs, and the chiefs used their gongons and they sensitized their people? Do you think that they would have abided by these protocols? Do you think that they would have seen these things as alien? My guess is that they would have seen it as part of themselves, and probably adherence would have been better than what we have right now. I agree with you, capacity is a challenge, but capacity is also a challenge at the national level. If we think it is the right thing to do, we can do the necessary investments to make sure it works.
Thank you. Joseph and Chibosiakun, would you want to ask your question now?
Yes, Prof, yes. Dr. Abekah, thank you very much for your presentation. I have just some few comments. Based on the WHO framework that you use, that 6 block that you use, I have read somewhere that the WHO emphasized on corruption as a barrier to achieving universal healthcare coverage. But in your presentation, I did not hear you mention anything. I mean, how corruption can be a barrier to universal healthcare coverage. So if you can maybe elaborate on that for us. Thank you.
Okay, thank you very much. So I think that corruption will come under governance and leadership. And I told you that within our health sector, a major issue is the structural configuration of the sector and the over-politicization of the sector. And so that creates the environment for what you will call dysfunctional behavior and therefore corruption. So corruption will come under leadership and governance. I think that corruption itself is not the issue because you cannot deal with corruption. What you can deal with is the environment that creates what I call the perverse incentives for actors to become corrupt. And so the arguments that I make in terms of re-looking at the structure of the sector and also depoliticizing the sector and making it a lot more autonomous, I think that that will create the sort of incentives, okay, for actors to be transparent.
Right. Aziz has a question. He says, could you throw a little more light on community participation and behavioral change? But he tries to link the question, and I'm not sure these are two related questions. Whether we have data and statistics on hepatitis B in Ghana.
Okay, so thank you very much. I would look at the first one, which talks about community participation. I mean, the point I'm making is that utilization is basically a demand and supply forces. But if you look at the components of the health system, okay, based on the WHO building block, it's basically around supply incentives rather than demand. And my point is that it's just like treating a patient when the patient doesn't have an input into your treatment plan. You are bound to fail. So a health system that does not seek to incorporate those around which the health system revolves, I would say that that system will fail ab initio. And that is the reason why I'm arguing that it is important to recalibrate the components of the health system around the communities, because who comes to seek care is the community and its members. And let's remember that there are variation in community characteristics, community needs, and the community is the best to engage with, to understand their needs, to understand the apprehension, so that we can design responses and intervention around their needs. And that, I believe, will be a major contribution to ensuring that we have positive outcomes.
Great. Aziz is still wanting to see if you have a model for fighting COVID-19 in Ghana. Is there a model? Do you want to share a model? He says either you or Dr. Nsiah-Asare, who is here to present.
Well, when he talks about a model for, I'm not too sure what he means, but if it is a model for fighting COVID-19 that you actually mean, I'll say that COVID-19 is basically an infectious disease without a treatment at the moment. So the basic way for fighting that based on public health is basically behavior change. And so I would argue that if it is behavior change, then the best instrument to deliver what I'll call a punch against COVID-19 is not institutional care, but it is primary health care, which starts from the community through the district level and a strong risk communication strategy so that you can prevent.
Gordon, Abekah-Nkrumah has will you go ahead and ask your question, please?
Okay, good evening.
Good evening, madam.
Yeah. I heard doctor saying that if we can give institutions the mandate to do their own things concerning employing and payments, is that not going to have a negative impact on our healthcare system?
Okay, Gordon, you advocate leverage for institutional control.
Okay, so thank you very much. I think that is one of the ideas that I'm throwing out there, that we seem to have major inefficiencies within our, especially the public delivery systems. And there is a study that shows that I think about 80% of all public facilities in terms of the efficiency threshold is below 50%, okay? And those who have efficiency thresholds, okay, higher than that is just around 20%. So that's one of the ideas I'm throwing, that, look, I'm asking a rhetorical question. Are we better off where we push all the public facilities, probably in to make them autonomous? When you make them autonomous and they have to pay for their salaries, okay, they have to make sure that their medicines and everything, they buy it themselves. The challenge that somebody will say is that it means that poor people won't have access. And I'm saying no, because that one is dealt with by a health insurance that everybody is covered, whether they have paid premium or not, and we have a defined package of service. So that health insurance is paying market rate. And when they pay you market rate, you use that market rate to be able to pay yourself and do everything, just like your private sector counterpart. Your private sector people, when they pay them market rate, they use that same amount to pay for their staff. They use that same amount to pay for capital investment, and they use that same amount to produce services. So I am asking, can we adopt that model? Maybe yes. And I don't think that it is going to lead to what you say, because the poor people will be paid for by health insurance based on the threshold of package of services.
Great. Dr. Justice Musa Issa Sulugu, go ahead and ask your question.
Thank you very much, Prof. And thank you, Dr. Abekah, for your elaborate presentation. I have one observation in terms of communication and putting the people at the center of managing the pandemic. In your presentation, you suggest that the approach, the top-down communication approach, has not been the best approach. But if you look at Ghana, you could realize that even various languages have tried to, translate what COVID is. So if you go to my village, even the old lady who is sick in the bedroom have heard about COVID and knows what is happening. So that tells us that there is that level of decentralized communication. People know what is happening, yet people are not observing the health protocol. So to what extent will you say that the communication has not been effective? And for that matter, we should use different model of communication. I would not want to agree that it is the structure of the communication that is preventing people from adopting the right protocol. But it's as a result of the structure of a society and the kind of leadership and how the behavior is moving from the leadership downwards. So I would want you to rather suggest different approach for us to use the communication to be able to get the people to adopt the right health protocol. But I also want you to review Ghana's performance so far. On a scale of 1 to 10, if we want you as a consultant to rate Ghana's government performance in terms of the management of the whole situation, how are you going to rate them? Will you give them 1, 2, or 3? Or will you give them 10?
Okay.
This question is very relevant because Dr. Nsiah is here. And as an academic, we must be very frank and using the data. How are you going to rate Ghana's performance?
Okay, great. The difficulty in rating things like this is that you will need to have had a marking scheme, which takes a number of things into consideration before you come about marking. But let's leave Gordon. We have a lot of questions on the chat floor now. So Gordon, be brief so that we can get to answer all the questions before we...
Okay. Dr. Sulugu, I hope Germany is very fine and you're enjoying the sun in Germany. Yeah. So yes, you said that you wanted me to change the suggestion I made. Unfortunately, I may want to disappoint you that I will not change it. I think that I'll still stick to what I said, that it is not more about the people. I think it's more about the approach. Because look, sometimes we underrate our people, thinking that they are obstinate, they are stubborn. I don't think so. Sometimes it's because we get things wrong. If you like, go to your mother's village and let the chief beat the gong today, that the god of the land has now appeared at one place, so they shouldn't go to farm tomorrow. bet you I can say that about 90% of the people won't go to the farm. Are they obstinate? No. It is you see, communication resonates from the source. So I think that yes, people have heard it, but yes, they've heard it as one of those things. But if it were the chief's palace coming up and having a discussion with them, now they see it as far away from Accra, okay, and it's difficult for them to really, if I would say, localize or contextualize what they are saying. Now you talk about rating. I think that because you are an academic and you have the data yourself and you know what is happening in other countries, I think that I would want you to rate it yourself rather than.
This is professorial style. Thank you, Prof.
Right. So I have so many questions. So we will try and see how we work on these. So I have Dr. Adfudazi says, the speaker advocates for the NHIS to be totally free. Don't you think to improve the NHIS, there must be some sort of cost sharing? And as enrollment increases, I fear the current funding wouldn't be enough to sustain it. And eventually it might collapse. Cost sharing can also serve as a form of indirect tax, and according to literature, can help reduce abuse and corruption. I feel it is better to pay a little to have it work than to make it free and eventually collapse. Comments?
Well, thank you very much. Yes, I agree with but I think we need to contextualize things. So you are dealing with a society, okay, right now, if you look at the poverty levels, okay, and NHIS is supposed to be pro-poor. Even at this point that they are paying those low rates, you look at the enrollment, okay, since 2003, it's hovered between 35 to 40%. And if you disaggregate the enrollment, it isn't majority poor. So my point here is, why don't we say, and in any case, what people are paying is just about 5% of the total contribution. So why not then say that instead of using that small premium to disenfranchise people, why not take it off entirely? In any case, the major amount comes from indirect tax, and the poor are disproportionately contributing more than the rich, because the point is that a major proportion of the income of the poor is spent on consumption, whereas for the rich, their income is more spent on investment. So in proportionate terms, the poor is paying more. So why do we want to use that payment to disenfranchise the poor? Wipe that off, let the government take hold of it, and let's give a cap. And that cap, we can use that as a basis for cutting down moral hazards. Because I believe that there are ways we can cut down moral hazard rather than just the premium.
So the conversation is getting exciting, but as we have it in our local parlance, while the conversation is exciting, then the night catches up with villagers. So I would take just one more question, and then we would ask Dr. Nsiah-Asare to present. And if we finish on time, we can get back to the conversations on the screen. And that question is coming from Dr. Abekah. Dr. Abekah is a medical doctor in Nkwanta District Hospital. He says, thank you, doctor. Concerning your advocacy for NHIS paying for the poor, how do we objectively determine who is poor, considering how informal our country's economy is? Gordon, and I guess that this question is also been a recurring question for even free SHS and other social intervention programs.
Thank you very much. For me, I would say that I will not link NHIS to free SHS. But Dr. Abekah, I think that the more reason why your question is even the more reason why I'm saying that nobody should pay any premium. that once we all pay taxes, okay, so that's the benchmark. Once we are all paying taxes, then everybody is enrolled, so that the poor does not have a disadvantage. They are not constrained by that small premium, which in any way doesn't contribute much to the NHIS. So if you scrap off that, then what is actually going to happen is that everybody is covered. But what we need to do is to be able to clarify the package of services, which we believe is synchronized with our health sector objective. And once that package of services is defined, it is then linked to the NHIS package of services, and every Ghanaian paying tax must have access to that service. And once they go to the facility will have to treat them. And then the facility will also be paid economic rates so that they can manage themselves properly.
Thank you very much, Dr. Abekah-Nkrumah. For the rest of you who haven't had the opportunity to ask your questions, I want to plead with you, and so we can move on. Unfortunately, we ask, and you can see Dr. Nsiah-Asare is still in the office, and so we don't want to keep him in the office for far too long. Otherwise, next time we call him, he won't come. But the conversation about payment and compulsory access, it's been a very thorny one. If you ask people to pay and they can't pay, how do you insist that they go to the hospital? And note that healthcare is not, healthcare is a public good. So if, for example, one person gets COVID, the society is in trouble. But if you say the person should pay and they cannot pay, then they won't go to the hospital, and they get infected, they infect other people. So it's a very complex dilemma that we have to deal with. But Dr. Abekah-Nkrumah, let me say thank you very much for this exciting presentation. Don't go, stay on, because when we finish, there may be issues that you want to respond to, or that at the end, you may want to have some thoughts on Dr. Nsiah-Asare's presentation as well. So now my singular honor.
I'm here listening to Dr. Nsiah-Asare, so I'm here.
Yes. The second presenter, as I said, is Dr. Nsiah-Asare. And as I said, he needs no introduction, really. Currently, he is the presidential advisor on health. In the not distant past, he served as the Director General for Ghana Health Service. Prior to that, he had served in Komfo-Anokye Teaching Hospital as the CEO. And if you know the nature of the complex nature of our tertiary institutions, you would understand what he has been through. Perhaps the reason why he has grade. But prior to that, he served in Tamale Teaching Hospital and a lot of other hospitals. He has been involved in a lot of research and has worked in different areas. He's consulted widely, and he is a surgeon general. So you can appreciate the weight of expertise that he brings to the conversation this evening. So we're going to welcome Dr. Nsiah-Asare, and Doc, we are extremely excited as a school to have you spend your evening with us because your kind of knowledge is difficult to find. So I want to welcome you now to speak to us on achieving universal health coverage by 2030, implications for health financing reform in Ghana. Thank you very much and good evening. Let me unmute you, Doc. I'm sorry. I think you are still muted. You can try and unmute yourself too. I'm trying to do that.
Okay.
Yes.
Can you hear me?
Yes. Now.
Yeah. Thank you very much, Prof, and thank you everybody this evening. I see that Gordon intentionally put me as a second speaker so that I stay in the office for a long period. But I normally don't go home early.
Great.
So it doesn't matter. Yeah. I'm going to quickly take you through the financing of health in Ghana, and I'll give you the introduction and also what we are doing in Ghana, how we also compare our health financing to the other parts of So the introduction, I'll go straight away and tell the Ghana government expenditure is of the total expenditure of health is about 60.6%. The private expenditure on health is about 39.4%. And external sources that are development partners about 13.2%. And as much as 91.6% out-of-pocket payment of private expenditure on health. Sorry. Hey, where am I? Please.
You can click on your mouse.
Yeah. Okay. So the total expenditure is the sum of the private and public expenditure. It covers the provision of health services, both preventive, curative, planning, promotive, and also nutrition activities and emergency aids like we're having now, especially in times of epidemic. But it does not include provision of water and sanitation. I'm sure you are all aware of Abuja GDP target of 15%. By 2017, the total health expenditure as a share of GDP was unfortunately about 3.3%. What it means, we are the health expenditure is increasing, but because you are also getting a lot, the GDP is also increasing. So if you look at the percentage, it's about 3.3%. The question is, how does this compare to other countries? And this, so if you look at Ghana, we started in 2000 at GDP, health expenditure per GDP of 2.8%. We went to 3.8, 4.6. And as I said, in 2017, we are about 3.3. Nigeria is about 3.8 in 2017. Uganda has 6.2. And Liberia, 8.2. And Namibia, 8.6. So Liberia has a very high health. The expenditure rate is about 13.4. We are getting to Abuja declaration. But we have to also look at how much the percentage is. The percentage, 3.3% of 1 million and 3.3% of 10 million are different in nominal terms. What is universal health coverage? The definition by WHO as at 2010 is that universal health coverage ensures that all people have access to needed quality, and my qualifying word is quality. Quality, promotive, preventive, curative, and rehabilitative health services. That's the holistic health services. While also we ensure that nobody suffers financial hardship when paying for these services. And that is universal health coverage. So if you look at what are the inclusive and sustainable social health protections, it is like a cube. And if you look at it, you have to look at the objective. The objective is equity in access to health services, and the quality of health service is very important, as well as financial protection. So we are looking at the access as population are well covered. So if you increase the population, you should also look at the service that the health service is covering, and then you also look at the financial protection. That's what people do and what they have to pay out of pocket. So this is if you look at it properly, this is the inclusive and sustainable health, social health protection, which will give you universal health coverage. The inclusive and sustainable social health protection systems are one, it should be affordable, acceptable, and also adaptable. So if you have to provide health services, which the public health has high value interventions and also financial protection, and the stakeholders should also accept what you are giving. They should have trust in it. And at the same time, it should also be adaptable, that it should respond to the changes in burden of disease, social and cultural and technological changes. If you look at it, sometimes back, what our burden was more of communicable diseases. And now we are growing to non-communicable diseases. So if you want to give universal health coverage, you should also, as much as possible, make sure that we also have to adapt to whatever we are having at the moment. So what does universal health coverage require? Universal health coverage requires that all people obtain health services they need without the risk of severe financial problems linked to the paying of the services. And at the same time, the health services people should receive should need to be good quality. So the quality is very, very important. It is not something that we can achieve in all countries overnight. However, countries must take actions to move more rapidly towards it and to maintain the gains that they have already made. That's exactly what Ghana is trying to do at the health sector. So we have to first look at the financial assets. If you look at globally, about 150 million people incur catastrophic expenditure when they access health, and about 100 million are pushed below poverty line due to out-of-pocket payment for health services. I'll give you an example. If you do a procedure for somebody and you need about 200 Ghana cedis, in Ghana, they don't call it 200 Ghana cedis, they call it 2 million. If you are not very careful, and the person has to pay the money out of pocket, the person may have to go and sell all what he has in his farm and even take a loan before he comes to pay. So that's what we call catastrophic expenditure. And you put the child who is going to school will have to go out of school. Anybody who is in the house, even the feeding, become a problem. That's the reason why we have to look at the accessibility of the vulnerable group as much as possible. All over the world, health insurance increasingly is being recognized as an effective strategy for financing equitable health care. Through pooling of risk, health insurance is pooling of risk and resources, and health insurance has the potential to ensure that we have improved access and quality access to provide protection for everybody. What is Ghana's main strategy to achieving universal health coverage? A key strategy in Ghana towards achieving universal health coverage is the implementation of our national health insurance scheme, which came out of Act of Parliament in 2003 and started using it or implementing in 2005. This is to protect people from catastrophic health costs and bridge financial access. The implication, therefore, is to enhance that we have instead of district health and mutual health insurance scheme, to introduce social protection mechanisms for the good people of this country. The NHIS was instituted to re-establish the relationship between health system and the household. We are working on the livelihood empowerment against poverty, that's how it started, and other community level actions to enable poorer and most vulnerable individuals and households to access healthcare and good nutrition. So that is, in a nutshell, the main strategy that Ghana wants to use to achieve universal health coverage. How do you understand National Health Insurance Scheme? Ghana introduced the National Health Insurance Scheme, as I said, in 2003, Act of Parliament, to mitigate the effects of user fees without working towards universal health coverage. In 2003, all what we are trying to do is to mitigate user fees. That's the reason why, if you look at health insurance, as it started and as it is now, it covers only the cost, some cost of services, not even the full cost of services, because health insurance doesn't cover the personal emoluments of the health provider. It covers only medicines and some non-medical items. And sometimes it doesn't even cover, for example, the number of hours that we use to do operations or see a patient. And that's where the problem is. The coverage as at now is about 34% to about 40 or 36%. This year it has gone slightly high. And there was a large benefit package. Our health insurance scheme covers about 95% of the disease burden of all Ghanaians. So you have to know that. And it's also financed about 85% from VAT, with minimal contributions from premiums. As Dr. Abekah said, premiums covers only about 5%. So some of the times that some of us sit down and look at it and say, why can't you forget about premiums and make health insurance compulsory for everybody? If you want to do that, it means you have to increase the other source of funding, which is the VAT and a small amount of money from social health, which is for the formal sector, which is a very small percentage of the people. So national health insurance also caters for indigents. In fact, if you look at the people who are exempted, a large number of people are exempted. That's people who are 17 years plus, people who are below 18 years, and people below 18 years in this country forms more than 50% of the population. And the pensioners and also social security contributors who don't pay anything because they contribute to social health insurance, and 2.5% of their social health insurance is paid towards health insurance. So there's a high exemption of health insurance. How, if you look at the historical context of health financing in Ghana, before the independence, that's before 1957, the colonial masters or the people who were running this country were financing the health services through out-of-pocket payment. When we had independence in 1957, so between 1957 to 1970, they have fully funded from general tax revenue. That was a socialist approach to health financing. And between 1970 to 1995, because of the economic recession in the country, nominal user fees was introduced to augment tax revenue. Because when it was purely free, it was financed through taxes. And in 1985, substantial fee payments at the point of service was introduced through our social, the subs and also loan conditionalities. They were forced to introduce what we call cash and carry. This brought hardships and ineffective exemptions. In 1990, the community-based health insurance schemes emerged, but it was very limited. It was in most of the child institutions. And then it became a political campaign in 2000 elections. And in 2004, the National Health Insurance Scheme was established through the Act of Parliament in 2003. So that is how the history of our health financing in this country has been. If you look at the mechanism of Ghana National Health Insurance Scheme, what you realize is that about 2.5% of the money that is in health insurance scheme is from National Insurance and Social Security and National Health Insurance Trust, SNIT, deduction from the formal sector, which forms a very small percentage of the population. And the funds from Consolidated Government of Ghana annual budget allocated, which is approved by Parliament. And these monies are from the 2.5% value added tax, that's VAT. And also we get money also from graduated premium from subscribers, which is a very small part of the funding. And then donations and grants and other voluntary contributions, and funds which normally accrue from investment. But if health insurance is in debt, it means the investment becomes very small. So national health insurance coverage is for indigents, that's the poorest members, and those lack of employment or visible source of income are not fixed, and they don't have any fixed residence. These are the people who are supported by some other people. We do this thing through means testing, and LEAP is where we get program which is reduce poverty by increasing consumption and promoting services among the extremely poor. So we use the LEAP, and then we also use the Ghana Living Standard Survey to get those who are actually cannot pay. 8.2% of Ghanaians are living in extreme poverty, as you all know, and more than 2.5% Ghana cedis on food per day. So we look at all these people, and currently only 2% of the poor are covered by health insurance, as the report in 2011. What are the achievements? The achievement of national health insurance over the years has given a significant contribution towards increase in health facility utilization. And also it has improved in health seeking behavior and unnecessary delay of care. So now those who cannot pay, if they have health insurance, at least they can get their hernias removed. Pregnant women who cannot hitherto pay, so they have to stay at home, can go to clinic, hospital for antenatal clinic. In fact, when Dr. Abekah was speaking, he said our antenatal attendance have increased considerably, and that one is through the National Health Insurance Scheme, which even hitherto was free maternal care, which has been converted now fully onto National Health Insurance Scheme. There's also increase in availability of services throughout the country, and we have seen a lot of private sector also coming into health, but unfortunately in the cities and the big towns. And there's now also some reduction of out-of-pocket payment. And this is all through National Health Insurance Scheme. What are the policy implications of health financing in Ghana? If you look at it, the increase in public investment for health, there's a need for more advocacy, and that's the importance why Ministry of Health and Ministry of Finance should dialogue. I'm happy to say that for the past 2 or 3 years, there has been a very strong dialogue between MO, Ministry of Finance and Ministry of Health. I'll give you an example. When I was the Director General of Ghana Health Service, at least we're able to sit down with the Ministry of Finance with data to show Ministry of Finance that we don't have enough human resources in the sector. And for the first time, we're giving our full human resources budget. That's the reason why if you look at 2017 to 2020, we've been adding a lot of health professionals and non-health professionals onto the payroll of the Ministry of Health. We also have to reduce direct out-of-pocket payments by increasing compulsory prepayment and pooling. This is something that we have to do to change the policy of health financing. And then the price and free controls between purchasers and providers. We tried as much as possible in the Ministry of Health, which we are trying to have what we call the pool procurement system, where the suppliers or the people who give goods to the providers will come together and control what they have to buy so that the price will be uniform. The more you buy, the better the pricing. And they want to also identify and close the gaps in inefficiencies. That's the need to increase attention on system efficiency. Health insurance over the years have been trying to use technology to improve the system efficiency. And then there's a need for constant attention to the poor and the vulnerable. And then we have a large informal sector, which still poses a challenge. So we should find a way of making sure that the informal sector is also taken care of, because we have to introduce a system. I've already been saying that it should be a system which will attract the informal sector to also, for example, enroll onto a National Health Insurance Scheme. That is very, very vital. So what is the call to action, and how do you move to the UAC agenda forward by true financing of health system? It is critical to address the challenges of lack of coherent health financing policies and weak partnership between the private and the public sector, and the weak and the fragmented health system, resulting in inequitable and inefficient provision of health services. I think Dr. Abekah has already alluded to that. It is also important and necessary that the health care service must be provided to the people who are in need, and out-of-pocket payment expenditure should not be outside the range and the reach of the people. It is important also to raise sufficient and sustainable revenues, and it's important to explore and improve domestic resource mobilization for health. We have to also to manage these revenues to pool health risk equitably and efficiently, and we have to ensure that the purchasing power of the health services in an allocative and technically efficient manner. And these are some of the things that we have to do, which I call the call to action. And I believe that if you do these things properly, and also government has to put emphasis on health financing through and ensure that we have protected against all forms of financial risk. And we have to explore avenues for the domesticalization of pool funding. There's a need to invest significantly in health infrastructure because we have learned from COVID-19. That's why recently, if you realize, His Excellency the President has put in what he called Agenda 88, because we don't want to be caught unawares. And we want to make sure that all districts will have a district functional, the word is functional district hospitals. And we should also have areas where we can have infectious disease patients kept. And every district hospital should at least have about 4 beds which can take care for intensive care units. There is also the need to invest in primary health care. As Dr. Abekah said, the cornerstone of achieving universal health coverage it's a true primary healthcare system. COVID, we are doing extremely well. Somebody was asking, we should give ourselves a marks. I will give ourselves a very high marks. Because apart from anything, when we're doing, since we are doing enhanced tracing, and we're doing tracing of all positive patients, their contacts, this is done at the local level by the sub-district and the district health management teams. And they are using the people at the community level. The community health nurses are the people who are doing this. And this is through our primary healthcare system. The increase in health budget should increase from the present 3.3% to demonstrate government's commitment in achieving Abuja Declaration. This is what we are working assiduously towards. And finally, Ghana government cannot achieve sustainable development goals if we don't achieve universal health coverage. And we can also, universal health coverage cannot be achieved if Ghana cannot achieve sustainable health care financing. Thank you. And I'll stop here for anybody who wants to ask any questions. Thank you very much.
Thank you very much, Nsiah-Asare. I am getting a lot of comments already under the chat forum about having access to your slides. And when your students are asking for slides, it tells you how informative they feel that the slides are. This has been a very, very well delivered, very, very loaded presentation. Lots of information, and I have learned quite a lot here. I know that my audience would want to get a pie of you. The first one that I have here is from Eunice Ajubi. She says, Dr. Nsiah-Asare, is NHIS enrollment compulsory by law? If yes, how is the law being enforced? And then the question from Joshua says, the delay in reimbursement of health facilities by the NHIS is causing the institutions delay in payment of contractors, which in turn affect supplies. This is a secular form, and it also affects quality of patient care. Please, what is the government strategy in addressing this issue? Then we have the question that talks about, okay, so the others are questions about receiving slides. But ladies and gentlemen, I can see Infinix Hot 8. Your hand is up. I'll let Doc answer the first two questions, and then we'll come to you for oral questions. But you can still post your question on the chat forum so that I can read it to Doc. Yes, Doc, please.
Yeah, NHIS, by the amended Act of Parliament, I think 2012, the word is shall. Everybody living in Ghana shall join the health insurance. So it's compulsory by law. And I believe that I've always been saying that health insurance should be in such a way of the new national identification card. If they are joined together, it means you take the national identification card, then you have to be a member of the health insurance scheme. And if you're a member of the health insurance scheme, so it means you have to be active and you should be renewing it every year. If for nothing at all, in times of emergency, that's where you see that you need a national health insurance scheme to work. And it's compulsory, but we have to implement it so that everybody has health insurance scheme, is also an active member. But we can do this. I have always been saying that it should be first and foremost that it should be enrolled on national health insurance scheme. And then if you want to take a reinsurance system of any of the private health insurance, you can do it. As Dr. Abekah said initially, if we do it well, then the health insurance will take care of all the basic needs, basic health care of the people of this country. And then anybody who wants to take a reinsurance system can take the reinsurance system. But to attract the middle class and the upper class onto the health insurance scheme, I believe strongly that there should be an aspect, even for nothing at all, once in a year, what I call adult weighing, which is in the government's policy document, which has been started. If you go to some of the district hospitals, they have a public welfare clinic, that's well-being clinic, where you can walk in and then check your vitals. If you're a woman, you can check your breasts, your cervix, and a man about 50 years can go there and check your prostate, do your BMR, do your blood pressure. There are a lot of people walking in the street in this country, about 30%, who are hypertensive who don't know. And it's also, it will, in the long run, be very cost-effective and cost benefit to National Health Insurance Scheme, because people will know that they are diabetics, they are hypertensive, and then come early for treatment. They may not even be on medication. So if you are looking at it, most of the health insurance people who are active, there's an adverse selection. It means people who are sick, the non-communicable diseases, are the people who normally are very active because they will use the services of the health facilities or health insurance. If for nothing at all, they don't pay consultation fees. So if you do it this way, the middle class and upper class, maybe if they are sick, their private health insurance will take them outside the country. But anybody who can do once a year, and I call it the birthday of every adult, whilst you are taking your child for weighing, you also go for weighing. And it should be paid for by health insurance. And this to me will be an attraction for people, especially those in the informal sector, to enroll onto the health insurance so that it becomes compulsory as is it by law, but you also have an incentive to join the health insurance scheme. The delay in payments, I would say yes, it's a contributory factor for also the cost of medications and non-medical consumables that people pay for. Because no businessman will bring you something which you say 3 months you pay and then you don't pay until after about 8 months or 1 year. You add all the bank charges to it. But what I would say is that it is much more improved. As we speak now, I understand that all the bills for 2019 has been settled. And I know that they've gotten some money to settle also the first quarter of this year. What we want to do, which we have sat down with the Ministry of Finance, is to make sure that we don't go beyond the 3 months, which is in the law, that once you send your submissions, you should be paid within 3 months. And if you do that, it means any submission that you send will be paid within 3 months. But we can do all these things when we use technology, so that from the claim submission, claims management, and even claims payment should all be done with technology, so that you have a seamless, and also you have a real-time submission. So anytime you see any patient, if you're using electronic health management system in all hospitals, immediately you see the patient who has a health insurance, it goes directly to the health insurance office. And then they can be looking at how you are doing and then also manage the claims and nobody delays. And the smaller facilities like the CHIP centers, the health centers, the maternity homes, the district hospitals should not even wait for any claims to be vetted, and it's because their claims are very small. If you have somebody's claim is very small and you don't pay it early enough, it means you are just collapsing the business of the health sector. And that is how I believe that if you work in this way, people will have appetite in renewing their health insurance. The facilities will have money to pay for the health for their procurement as early as possible, and this will force suppliers to reduce their price. In addition to also going by the pool procurement system, that every supplier knows how much maximum that he can sell and the minimum. If it's go below that minimum, it means you take that the commodity that is bringing you is not standards, and you shouldn't go above the maximum. And if you do that, we'll get value for money for whatever we are doing. And if you bring in the health promotion and health education into the system, health insurance will not be paying for things when people come very late with non-communicable disease, which is actually what people are paying for now.
Great. I tell you, the conversation is very hot and interesting, but we will do as much as we can. I'll read 2 more questions, 3 more questions on the chat, And then we will give our colleagues who have shown by hands that they want to ask questions opportunity to ask their questions. This one says, is it possible to achieve Abuja declaration of 15% GDP allocation to healthcare in the next 5 years? Nyame Anan says, please, can we know why the health expenditure does not include provision of water and sanitation? And that's a very important question because a lot of our diseases are health, water and sanitation, based or induced. And then I have Fanny says, will the COVID-19 pandemic affect our goal to achieve universal health coverage? How is the government ensuring that our health system is resilient in the face of future pandemics? And then perhaps the last one in this one says, are foreigners from other countries allowed to be enrolled on the NHIS? So Doc will ask you to answer these ones. Maybe I should add one more so that we can take them. This one says, from Obedosei, can we know what percentage that the premium payment contributes to the entire financing of the scheme? Not sure that I understand the question, but it says, and isn't it possible to scrap and add to different financing sectors so that the poor will be relieved? Because we at the villages see day in, day out how the poor are denied some care because they are not covered and cannot also pay from their pockets. That's a very, very important question, and I want to join that question. Like you said, the law says health insurance, everybody shall register, but you go ahead and say pay a premium. And so those who are able to pay the premium, which constitutes just 5% of the total cost of the health budget, have access. And those who do not pay premium, which is just 5%, are denied access, which 95% of which is actually funded by tax money. So by virtue of the fact that somebody pays 5%, he's entitled to his 5% plus 95% tax money. And by virtue of the fact that I am poor and I'm unable to pay the 5%, I am denied 95% access to tax money. Now that creates a discriminatory policy where the poor who cannot afford are discriminated by a national policy of this importance. Doc.
Yeah, I'll start from your question. That's the reason why I always tell people that if you buy water, Insu, or any water that you buy, you pay VAT on it. And the VAT that you pay, 2.5% of that VAT that you have paid will be used to finance health insurance. But the fact that you have not gone to pay the premium, not that, okay, those who can pay at all, there's a means test of taking care of them. But there are some people who can pay, but you tell you, I'm not sick, so I won't join the scheme. If you are a member of an organization and you don't pay your dues, when the benefits of the organization come in, you are not giving the benefit. So health insurance, we are all beneficial to it because we all contribute towards the part. So the most important thing is either we say nobody pays premium, and it means the 5% of premium, we try to get it from other source, either by increasing taxes, which nobody wants to pay more taxes, or we find a way of getting that money. But in the meantime, once we say that there are some people who should pay premium, I think contributing as less as 35 Ghana cedis a year towards your health is a good investment. So meanwhile, I believe that we should encourage everybody that at least if you are in the informal sector, just take a small amount of money and pay towards your health. And Prof, if you do that, that's the way that you will not be cheated because you are not getting the 95% or that other people have paid. In the same way, if you look at, for example, SNP holders, the money that they deduct is part of their social security. And that is why they don't pay the premium. That's how it was set up. So we should have to look at it again and see, as a nation, if we say that everybody should not pay premium, and then we all maybe add something small so that we tax towards our health. Health is very important. If you go to other countries, if some of the people pay as much as 25% from their salary towards health, and health is expensive. So that's what I would say. The next question was the premium of scheme. What does it? Yeah, it doesn't cover. Yes, health insurance have been working from a system where they have the exclusion list, and that's what makes it difficult for most facility providers to also know what exclusion list is. So there's a lot of human factor there. If the person believes that the money that health insurance is paying doesn't cover what he's doing, then they bring in that it doesn't cover. But going forward, what we believe in is that every health facility, both the various people are trying to cost. So people are doing costing. The private sector, the child public sector, the teaching hospitals, and I believe strongly that the only way is maybe once a year or every other year, they sit down together and negotiate with the Minister for Health as maybe the arbiter, or somebody from the ministry as an arbiter, and they sit down to negotiate proper costing of services. And I'm saying this because if you have been a chief executive or medical director before, then you see the importance of maybe having the real cost of services. I will even go further and say, if possible, why don't you give all the money for personal emoluments to health insurance? And health insurance pays for the full service. It's done in other countries. If you go to Korea, that's what they do. They give per capita, and that's what they pay. That if there are 50 million people in Korea, they have achieved universal health coverage. Total, I think about everybody is on some of insurance. So the per capita is $100 a year, and they multiply it and give it to health insurance. And it is inclusive also the personal, the remuneration of the health workers. If you do that, it will help us to redistribute our health force. So if the bigger hospitals in the cities are not seeing more patients, and those in the villages are seeing more patients, it means they have to let some people go off, and they have to go and look for a job in the other places. And that will eventually bring redistribution of the workforce that we have. Foreigners, the health insurance law say that not only Ghanaians, say everybody living in Ghana should or shall have health insurance. Because if somebody is a foreigner, is living in Ghana, what it means is that if he's here and he comes here, for example, COVID-19 or cholera, and he cannot take care of him or herself, he will infect a lot of people. So foreigners are also part of health insurance. The resilient health after COVID-19, that's exactly what the government is trying to do. If you look at the 6 strategic directives of the government in fighting COVID-19, the last one is saying that we have to build a capacity of the local capacity and also ensure sustainable development in this country. That's the reason why, if you look at it, we are trying to allow the personal protective equipment that we have now. The masks are all locally made. The sanitizers are locally made. A stimulus package for industries, especially pharmaceutical industries, to produce medicines for COVID-19, like the vitamin C, the zincs, also hydroxychloroquine, and the rest. So we want to be very resilient, and in future will not be taken away. But I can tell you that nobody is well prepared for any epidemic or pandemic, because we all saw that the epidemic started in Wuhan as far back as early January. Everybody saw it. But mighty countries like America and the European countries couldn't even get well prepared. So we normally go continuously be preparing for epidemics, but we want to build a resilient health system, especially for communicable diseases, so that we have at least 3 infectious disease centers in the 3 ecological zones of Ghana, and also make sure that we have the human resources to also man these places, and we have to back it by research labs and research institutes. And in the long run, we'll have a well-built Ghana CDC. And at the same time, we also want to make sure that every region, the new regions, all have functional regional hospitals. All the districts, the 260 districts in Ghana, will have functional district hospitals. And with infectious disease centers, with at least 4 beds for intensive care units, so that we can take care of people wherever they are. And those who need extra care will then go to centers of excellence. What is the goal to achieve universal health coverage? That's why I say that you cannot achieve universal health coverage without, you cannot achieve sustainable development goals without achieving universal health coverage. And our goal to achieve universal health coverage is through our national health insurance scheme, and also through our primary health care system. So if we have primary health care system from the community level to the sub-districts to the district level are strengthened, then nobody walks a distance to a geographical distance to access health. And when the person goes there, you should be able to access the health without any financial encumbrance. And then water and sanitation. Yes, water and sanitation is not part of it, because water and sanitation is another sector. So if you add water and sanitation to the health service budget, then the expenditure of health will not be 3.3. I'm sure we'll be getting towards maybe half of the Abuja Declaration. These are things that we are working together with water and sanitation, and even with local government, to make sure that we can then have a composite budget and look at the expenditure of water and sanitation. This is something we'll be discussing with water and sanitation. If you go to other countries, I'm sure Sierra Leone will have a very high percentage. Maybe water and sanitation is part of the Ministry of Health, so that it will be a composite budget. So are we going to achieve the Abuja Declaration in the next 5 years? It's work in progress. We are working towards that. I can say that a lot of things have been done to achieve a higher percentage of expenditure of GDP towards health. And delay in payment, I think I've answered that already. So these are the questions that you asked, and I think I've managed to do justice to most of them.
Yes, please. I have hands up. I'm going to allow them to ask their questions, and then I'll come back to the first and foremost. Let me go to Tim. Are you there? Please unmute yourself and ask your question. Then I'll go to Professor Frank Ohime. Tim, are you still around? Yes, go ahead and ask your question.
Yes, I am. Thank you very much, Prof. Baule, and thank you to Dr. Nsiah-Asare. My question actually relates to why some package of services are not included in the NHIS, in particular nutrition services. I am a nutritionist, and I'm very concerned that nutrition services are not included in the NHIS package of services. But I'm quite happy to hear that Dr. Nsiah-Asare talked about the fact that they will be including weighing of adults in it, which is part of a nutrition intervention. But currently, we have like management of severe acute malnutrition, which is not included in the NHIS. It appears as economically we are improving as a country, we tend to take for granted the importance of nutrition in the health of the Ghanaian populace. And I think there is an area we need to look at. So I would like to know from Dr. Nsiah-Asare what government's plans are to include nutrition care services into the package of services provided by the NHIS. Thank you
very much. Now, thanks, Tim. Now I go to Professor Frank Ohime. Professor Frank Ohime is reaching us from Canada. Tim, where did you reach us from? Are you in Ghana?
Yes, I am. I am in Ghana.
All right. Okay. So Frank Ohime.
From Sunyani, to be precise.
Okay.
Thank you very much, Professor Baule. And pardon me, because I had something came up when Professor Nsiah-Asare started. So I lost a huge chunk of probably his presentation. But I picked a few things from some of the way he was answering some questions. And I'm not sure whether I would say, for example, I disagree with him, or the government policy, or maybe the government policy itself is flawed, and whether they have tried to look at it, the policy from a holistic perspective. The first point he talked about was premium. That if you can't pay the premium, then you don't join NHIS. I think that goes contrary to what governments are supposed to do. Governments are supposed to take care of the vulnerable, whether you can pay or not. That is why some of these social issues are funded through what you call the tax network, so that people who can afford will be able to charge certain things, to pay certain things, while those who cannot afford can have some basic services. I'll give you a good example for Canada. In Canada, tax system comes straight away from the taxes. However, depending on the work that you do, you pay premium. So not everybody pays premium, but everybody gets basic services from the government because of that system. Second, the problem that I have come to realize, I'm not a health expert in that, but looking at the policy, one of the fundamental problems affecting Ghana's healthcare policy was that the policy was poorly and badly designed. And I'm wondering whether they sat down to rethink about how to design the policy. Let me explain a little bit. In Canada, for example, nobody gets, for example, medicine based on healthcare insurance. So if you go to a hospital and, for example, you are prescribed, let's say, chloroquine, the hospital is never going to give you the chloroquine. You have to either have a private insurance that pays for your medicine in such a way that every job, for example, University of Ghana may have its own private insurance that pays for those medicine. Therefore, the medicine thing doesn't come onto the government or the health system. And that is where part of the corruption comes from, because we know there's been a lot of emphasis in which pharmacists and doses at the hospital find a way to get that medicine out. And that comes back to how the policy was designed from the first place. So I'm wondering if they have critically looked at the policy in the first place to redesign it to make it a good policy rather than a political policy. That is my issue. The second point, again, he talks about foreigners, which is related to the first point. Again, in Canada, for example, you come here as an international student. You are considered as a foreigner. Therefore, you do not have access to the healthcare system. You have to get what you call university health insurance policy. University health insurance policy. And it is that policy that you have to take to a doctor or to a clinic. Therefore, when you are charged, the hospital goes to that insurance company because you have paid the insurance and the hospital gets its money. So again, coming back to the policy design, this is a flawed policy in the first place. So if we want to make the health insurance a good policy, we need to go back to the policy and redesign it and not make it a political policy, but rather a good policy. You see, the policy idea is extremely good, but the fundamental problem is how the policy has been designed. And until that we go back to that fundamental policy, the problems associated with the NHIS will continue. And no, even Jesus Christ cannot solve that problem because we have gotten the policy design wrong in the first place. That comes back to something that Dr. Nkrumah said. I listened to Dr. Nkrumah. He talks about efficiencies. How do you put those efficiencies in the first place? I remember a couple of years ago, when I came to Ghana, somebody asked me that question. And I said, you see, before they should have put the NHIS into place, the first place they should have started was to have a computer system at the district level, linked together. So if I pay my health insurance, for example, at a bank, you see, instead of people seeing money, instead of going to the district assembly to pay money, I can go to a bank and pay, and immediately the money will go system, assembly system, where the central government will also coordinate and know what is coming in. All these things were not done. Therefore, inefficiencies that Dr. Nkrumah, for example, was talking about, I mean, I have a whole lot of things to discuss with Dr. Nkrumah on that, will not be resolved because the system itself, the way it's set up, doesn't create a situation for inefficiency to happen. The system is such a way that it will continue to create inefficiencies in the system. And that comes to the part that until we fundamentally attack it, redesign the policy in such a way that it will benefit the citizens, I don't think the issue will be resolved.
Thank you very much, Professor Ohimi. I think part of the challenge you have thrown about policy design is probably why we exist as academics, so that we can prefer some criticisms to the policy processes, and so that there will be continuous review. But I will leave the very able Dr. Nsiah-Asare to fight answer his questions.
Thank you very much, Prof. Ohimi. Yes, I mean, you are coming from a society which uses a lot of technology to do things. We started from an angle where technology was not much used. But I can also say that if you want to wait to have technology everywhere and fully established, then you may not have started health insurance at all in 2004. I think we've made some modest progress and achievements. As you speak now, you can now renew your health insurance card or premium, become active member, just by simply going to #929 *929#. And you can renew your health insurance and pay your premium without taking cash to any office. We are encouraging a lot of people to do that. We have also put in a lot of things to make sure that the health insurance is using technology to be very efficient, so that to use computerized system. As I said, for renewal of your SHS cards, to claims management and payment, this is being done. Actuarial studies is being done to see if the premium that people are taking are paid, and also the amount of money that Parliament also gives to health insurance, how much goes into administration, how much of the money comes directly, because 2.5%, if the economy expands, 2.5% of VAT also becomes bigger. But the amount of money which is used for claims management and the amount for administrative costs, if it is 80-20 or between 75-25%, the health insurance will be sustainable. And if government releases at least 80% of that money to health insurance, it also becomes sustainable. This conversation that health insurance is having with the Ministry of Finance and Ministry of Health to make the system become efficient. Premium, yes, those who cannot pay, they are poor and vulnerable people in the system. And through means testing and using the LEAP and the Ministry of Social Welfare Gender, we are now putting a lot of people on health insurance who cannot pay. And this is done at the district level, and the names are brought, and people who cannot pay are actually exempted. From 2007 till about 2009 or 10, what was happening is that there was even free maternal care, because you wanted pregnant women to have access to health without even paying. But the question is, how do you tell Ghanaians that you can pay, so go and pay? That is where the problem lies. I know the system is talking about, there are some systems where there's co-payment. Somebody will tell you that co-payment maybe is the most efficient way. But if you say co-payment, the fact that the person is going to hospital, if you don't give the person treatment, and they say the person should go and take somebody who cannot even pay the small premium of about, the premium is not even static. The premium that people are paying is according to where you live, the district, the sub-district that you live. Somebody who is living at Ayawaso West, premium is different from somebody who is living in my village. So this is all graduated. So if that such a person cannot pay 22 cedis or 18 cedis a year as a premium, and the person go to hospital and he has to go and get his medication of a private health insurance scheme to pay for it. In Canada, you can do it, because Canada, a lot of people are in other formal or informal paid services. But in Ghana, we have a lot of people who I call they are on a daily substance services. If they don't go out to get money, they cannot even pay for even food. So if you do that, what it means, you are going to cut a lot of people from getting the real quality service. You come to hospital, he's seen, he's given a prescription because he has no private health insurance, which premiums, their premiums cannot be paid by anybody. Yes, those informal services, formal sector can, because your organization or your company can pay for you, and then maybe you pay some small amount of money through your unions. They negotiate for that. But what about the ordinary person? What about the ordinary person in a small village? How the system that you are talking about, how is that person going to pay for it? That's the reason why in Ghana, we set up the system in such a way, and everybody believes that for the basic health service, at least, even though about 95% of the disease burden was covered, but at least for basic health services, it should be covered. As I said, I've been to Thailand to look at their system. Health insurance even pays for dialysis and kidney transplant. But in some countries, no. So you have to look at the dynamics of the country. You have to look at the socioeconomic situation of the country before you can also do some policies to make sure that people are not cut off. From what he's saying, I'm prepared to maybe meet him and then we'll talk about it. I believe what he's talking about, if you institutionalize it in Ghana or you make it as a policy in Ghana, a large percentage of the people cannot access health services because you go, a doctor or a pharmacist or somebody sees the person, but you cannot go for the drugs. And the most important thing is the drugs. Because if you don't have the medicine or you don't have the necessary advice, there is going to be a problem. He also, so I've spoken, and the foreigners having access to healthcare. Yes, foreigners who are coming to school can maybe through the universities add also an insurance system. And then the private health insurance people in this country who can take it up and then add it up and then give them their medications. But if somebody is living in this country and the private health insurance premiums are out of the reach of the person, we cannot say as a country that you cannot also be covered. So if the person can pay, when we travel, the same thing, we take insurance cover in case that you have any emergency, you can pay for. Ghana, too, when some people are coming here, I think they also take insurance cover. But it means our health insurance, private health insurance scheme should also be, their premiums should not be out of the reach of the people. But as I said, those who cannot pay and they are very vulnerable, the people go through means testing. But I'm talking about people who can pay but are not renewing or becoming active members of health insurance. If you look at people on the health insurance scheme
broke my heart. Why?
Record program, there are a lot of people, millions of them.
Who broke my heart? The way they.
Who broke your heart?
When I saw the announcement, it broke my heart. Please, 1 minute. Let me throw back to see.
No problem.
Sorry.
Yeah, Prof. So that's it. So acute malnutrition, yes, because it is not part of health insurance because it was taken care of by a project. But once you are moving out of programs, like the same thing like HIV/AIDS is also covered by a project. Same thing like TB. But going forward, we are also trying to bring all of them on board on health insurance. Even family planning. There are schemes, we are doing a pilot in some districts to bring family planning onto health insurance scheme. So we'll make sure that acute malnutrition, which was hitherto by special projects, will all be part of the health insurance scheme. Thank you.
Thank you very much.
I have a question.
Dr. Nsiah-Asare, I have Musa Isa Justice is itching to ask his question. Dr. Asrugu, please make your question very snappy so that I can read other questions from the chat room.
Thank you very much, Dr. Nsiah, for your time. I have just two questions. One, you appear to agree with Dr. Abekah on scrapping premiums. As a presidential advisor, when should we expect policy position on the scrapping of premiums? The second question is that you appear to list number of projects that will make us have very robust health system. But if you compare 2010 and 2017 government expenditure as a share of GDP on health, there is retrogression. How are you using this data to support the numerous interventions
that you have listed, because we should see rather improvement, progression in terms of government expenditure. But the data you presented shows that there has been significant reduction from 4.5% in 2010 to 3.3% in 2017. And if we are to use that trend, it means that in 2019, 2020, we are going to have less than 3.3. How are you defending this data against the numerous policies you have mentioned? Thank you.
Great. Doc, please note that down, and then I'll get a few more questions so you can take them together, and then we'll try and see how we can go on. So there is one that is linked to a question you answered already, which talks about that at current rate of 40% enrollment, our health NHIS is wobbly. If we were to go up to enrollment of up to 80% with the current status quo in terms of funding portfolio, we risk collapsing the health insurance. So when we make the argument of let more people enroll, at the current rate, we are suffering. So if we enroll more people, will we collapse the system? And that came from Dr. Afodazi. There's a question from, and there have been a couple of those questions about additional fees or fees that people pay when they go to, even people who are on NHIS, when they go to hospital, they are asked to pay additional fees. And there are illegal fees. Some are manipulative fees, I choose to call them, where even though somebody is on health insurance and would be entitled to some medications, the hospital tells you we don't have. And then you have to go and buy. And my particular worry, maybe to join that question, is the issue about the lack of transparency. When I go to the hospital and I am treated, I do not know what I have been charged for. So I can be given one paracetamol, and the health insurance, the facility can charge me for jack number of things. How do I verify that the one paracetamol I was given is exactly what the health facility is submitting to health insurance for payment and stuff like that? The other question here is coming from Dr. Nyamiche. He says, I'd like you to throw light delays in the disbursement. I think he talks about delays in disbursement, and that comes from health facilities as a result of unrealistic claims or errors in the submission of claims. Some institutions even make double claims. Due to some of these challenges, the National Health Insurance Authority needs time to scrutinize the claims. This partly results in delays. Part of the solution involves training of revenue collectors and clerks. So a question about delays, and I think there's also a number of questions related to delays and reimbursement. For example, the question from Ishan talks about now most health facilities, if not all, are making patients pay additional bills according to the NHIS, which is illegal. And as a practitioner, I know how difficult it is for patients. You said people get their hernias repaired with NHIS, but they pay for it in addition to their NHIS. I hope a timely reimbursement would push NHIS to really act to stop this practice. So a couple of questions related to, if you like, the management challenges that the Health Insurance Authority faces in terms of its relationship and management of claims and stuff like that. You can take these together and then we'll see what happens next. Thank you.
Yeah, thank you very much. I will start with the delays in the payment of claims and then the disbursement of payments and also illegal fees. I think I alluded to the fact that health insurance and the providers, both private and public providers, are now having a roundtable conference to come out of proper costing of services. The illegal fee payments, addition payments, and all these things will be sorted out if health facilities and providers have all their bills covered. For example, I'll give you an example. That's what the health providers are talking about. For example, government is no more taking the utility bills. So the question is that who pays for the utility bills? And they believe that utility bills should be part of the service provision. So all these things will be worked out, and they are being worked out in the costing. So you look at the costing, you look at the volumes, and you look at what can be paid. And this can all be done through negotiations. As we speak now, there's a team which is costing all the services. There's a team through USAID who have also worked on the actuarials for the health insurance. That's why I alluded to the fact that depending upon the amount of money of the VAT and the SNIT, which comes to the government funds, if a percentage is given, and the percentage which is given, if another 80% is given for reimbursement of services provided, and only 20% for other administrative costs, the health insurance scheme will be viable. They said that 80-80-20, or at least 70-30-20, or 70, yeah, if it's 70% payment from government, and then about 70% of the money is used to pay for the claims, or 70-75%, and also 25-30% is used for administrative costs. It will work. But we all agreed that if it the 80-80-20 will be the best. So this is what the actuarial studies have also come out of. And the actuarial studies also came of services which will be covered fully by health insurance. And it's inclusive the disease burden, inclusive health promotion and health education and the nutrition, family planning costs. Because everybody believes that if what is costing the health insurance a lot of money now is non-communicable diseases. You can cut non-communicable disease to considerable amount if you detect early enough and you put the patients on medication or on treatment. If you see somebody who is developing diabetes and the patient is advised only on nutrition and on exercise and weight loss and the rest, you may not have to give the patient the very expensive drugs. If you detect hypertension early enough, which most people don't know, then the patient doesn't go into very high malignant hypertension and even to stroke, where you spend a lot of money on the patient. So that's why I said that it has generally been agreed. We want to know how many times what goes into it. These are all being worked out. The increase in the collapse of system, because 40% people are on the scheme who are active and the system is not working. The system is not working because of reimbursements or the release of money from the government consolidated fund. That is something that also have roundtable conference and spoken about. That's the reason why recently, if you ask any provider, a lot of claims are being paid, and they are working to a situation where the claims will not be more than 3 months of claims which have been submitted. How do you get the claims also early enough so that claims management will not be flat with a lot of corruption and illegalities? That we can only do through technology. So if you have electronic claim system, which is about only 25% of all claims being worked, the rest are all manual. Now you have full electronic integrated seamless claim system for seeing the patient through the submission of claims and then the analysis of the claims and payment of the claims. So claims management will become a very seamless thing, and people will get their money early enough. Because as we speak now, even though we have a 3 months or 2 months window period for submission of claims, some people forget and submit claims after about 6 months. And now if you submit claims after that period, it will be paid. So these are some of the rules that health insurance have put in place. And yes, you said that if you ask me, do I believe in scrapping the premiums? I believe that this should also be looked at. But if you are scrapping all the premiums, and nobody pays the 5% premiums, then we should get money from somewhere to fill in the gap which should be open. So as a presidential advisor, that is my advice that I'm telling health insurance when you meet them, and we are trying to find a way. But at least people should be made to know that once it's not done yet, it has to be, everybody has to be on health insurance. And we have to improve the data that health insurance have so that we get the proper data for also planning and budgeting purposes. Thank you.
Thank you very much, Dr. Nsiah-Asare. I think that we have really drained you this evening, and at this point, I think that we should bring the curtains down. There are still a few questions here, but forgive me. It's almost 8:30, and I think we should end it here. There are some explanations, in the chat room answering some of the questions that have been asked. For example, Maxwell talks about the fact that the differences between how much the health insurance pays and the real cost of providing the service is often absorbed by the patients in the additional fees that are charged. And Doc explained a bit earlier about utility cost and all of that and what have you. So I guess that the conversation about the real cost of services, a very pragmatic way of looking at it and making sure that it is at a margin that allows even private facilities to want to still remain in business and to continue to accept health insurance as an option is something that is very important. I want to say a very big thank you to you, Dr. Nsiah-Asare, for giving us your evening. We appreciate this as a school. We appreciate this, and I can say that this has been a very, very useful session this evening. At peak, we got about 110 people at a time in this seminar. People have dropped and joined, so I estimate about 150 people have gone through this seminar at one point or the other. And I am extremely excited that you made time for us. People are asking you to give us your slides because they want to have access. People have also asked us for the NHIS annual report, if you have, so that I know researchers will want, their researchers here, they want to be able to throw some things down and all of that. Dr. Abekah-Nkrumah, I want to thank you for your presentation, but thank you for pulling us one to get Dr. Nsiah-Asare to come this evening. For all of us, all of our colleagues who have joined us, Professor Ohiming from Canada, Dr. Surugu from Germany. We often have people across the country. A lot of the participants here are also health practitioners, nurses, doctors, pharmacists, and all of that. And our students in our clinical leadership and management program, it's a master's program in clinical leadership and clinical leadership and management. Close to 80 of them joined as well. So this has been very, very, very useful. We are going to edit the video and get it published on our YouTube channel so people can go back to it. But it's my singular honor to declare this session over. But I want to thank all of you so sincerely for all of the great discussion this evening. So thank you very much. Noah Tunfu, thanks for joining. Yesterday,
thanks, Prof.
I want to thank all of you. Once we get the slides, we will put it on our YouTube channel so you can download it from there. Sending the video that we have now is going to be very heavy. So we would edit it and put it on our YouTube channel. But Doc, salute from me.
Salute. So I will send my presentation to Dr. Abekah.
Yes, please. Thank you very much, sir. Thank you very much. We appreciate it. So, ladies and gentlemen,
Bye-bye.
take a good rest and enjoy your evening. Catch you up. My students are
And you too.
coming.
Thank you, sir.
Thank you.
Thank you.